Hello, my dear future nursing officers. Welcome you all to the Master Nursing classes. So, in this today's very important session, we are going to discuss the most important questions, concept. As like previous two sessions, I used to revise all the golden points by holding the one important multiple choice question. So, I am revising all the necessary points that is necessary for our upcoming Norcet exam. Right? So in this today's session also, we will hold one particular question, we will discuss the disease and we will revise all the golden points on that particular disease that is necessary for our upcoming Norcet exam and any other central government exam. Students, ये सब कुछ पढ़ने का टाइम नहीं है. This is the time to study only that much content which is necessary for your exam, because we don't have the much time here. We have the little time, the best quality time, so we have to use that one wisely. Okay, believe me, nothing will come out of my box what I am telling in this particular sessions. Okay, if any question is coming from this topic, it will come from my box only. Okay, so please do remember the very important thing: while attending the class, be completely attentive, don't sleep in my class. Okay, and I will not allow you people to sleep in my class. If requires, I will sing. If requires, I will dance in front of you people. Okay, don't worry about that one. Right? So I want everyone to completely be attentive and completely watch the class till the end. And wherever I am asking the single liner questions and wherever I am creating the situations in front of you regarding that particular question, please be try to answer and respond to the every questions what I am asking to you people. Okay, yes, well done beta. So we will start the today's session with this powerful motivational line. Beta, in your life, never ever don't try to impress others, improve yourself, so everyone will get impressed you. Right? So don't waste your high quality time for impressing others. Okay, yes, you are improving yourself, everything will come to you. Okay, there is no need of the impressing others if you are improving yourself. Right? So with this powerful motivational line, we will start the today's session. And here's the first question in front of you all. So please do read the question carefully, completely, and try to give the best answer for this question. Fadafat. Yes. Which of the following is the classical clinical symptoms of the asthma? Option A, chest pain. Option B, productive cough with fever. Option C, wheezing. And option D, bradycardia. So what is the classical clinical symptom of the asthma? Okay. So beta, fadafat do mention your answer in the comment box. Classical clinical symptoms of the asthma. Yes, almost all people given the correct answer. There is the wheezing. So my second question is whether wheezing happens during the inhalation or during the exhalation. Yes, in the option A, that is the inspiratory wheezing. In the option B, there is the expiratory wheezing. So which one is the correct answer? Consider in this question only they have given the two options like inspiratory wheezing and expiratory wheezing. So which one was to the correct answer? Yes. So wheezing happens during the exhalation or during the expiration. Whenever we are trying to push the air outside, that time the sound will come here. Okay, so that's the expiratory wheezing happens here. Okay, so very important. Do remember with mnemonic. So in the wheezing, double E is there. Double E means it happens during the exhalation or the expiratory wheezing we will get here. Okay, yes, in the inspiration also wheezing sound will come, but it is dominant during the exhalation. Do remember the very important thing. And answer C, every one of you given the correct answer, and I am very proud of you. So give me a 5 to 10 minutes. I will revise entire asthma in front of you, and I will create all the situations which is necessary for your Norcet exam and any other state and central government exam. So in the last class, we have studied the very important golden words on the asthma. Better asthma is in the so we have started with this question. Okay, so where the patient with asthma prescribed both salbutamol and budesonide. So what is the correct nursing instruction we have to give? So with this particular concept I have started, where I have explained nursing instruction to the patient with asthma. We need to start with the bronchodilator. First we will give bronchodilator, then after that we will give the steroid. The rationale behind that one, I want to dilate the bronchi first, then I will give the steroid so that the steroid can go deep in the respiratory system and it can reduce the inflammation. Okay, so if different drugs prescribed means first give the bronchodilators, then 5 minute gap, then the steroids. If two same drugs are prescribed means two bronchodilator prescribed consider, or the two different steroids consider. Okay, so first your dose you have to give, then 1 to 2 minutes gap, second dose, very important. Okay, so next golden points on the asthma. I told asthma is on the it is in the chronic inflammatory disease condition, means it is not arises in the one day and it will not subsides in the next 7 days. So this asthma will be a 10 year together, 15 year together, 20 year together the patient will experience. Okay, so it is in the reversible condition because FEV1 in the asthma will goes less than 70%, and whenever I will give the bronchodilator, it will comes to the normal. So I call this one as the, it is not an irreversible condition, it is in the reversible airway obstruction, the very important first point. And it is in the airway hypersensitiveness, or we can say that it is in the airway allergic condition, where the airway is responsive to the external allergens like a household dust as the most common risk factor for the asthma. In the study class we have discussed the most common risk factor for the asthma is the household dust or the household allergens. Okay, so here in this particular condition mucus overproduction also will happen. Okay, so do remember in the causes we have discussed extrinsic cause, intrinsic cause. In the extrinsic cause there will be an increase in the immunoglobulin E and histamine, because this extrinsic cause is due to the external allergy. Whenever there is an allergy, which immunoglobulin will increases? Yes, do fatafat comment in your comment box. In allergic condition, which immunoglobulin will increases? Already in the crash course sessions, whatever the classes I am sharing in your group, in the first class only I have covered the immunoglobulins. Okay, so all the types of the immunoglobulins and all the golden points on the immunoglobulins we have covered in that particular session. Okay, so crash course session number 1, whatever I shared in your WhatsApp group. Okay, yes, very good, beta. Okay, immunoglobulin E is the very abundant immunoglobulin which will increases in the allergic conditions. Okay, so which immunoglobulin will crosses the placenta? Yes, which immunoglobulin will crosses the placenta? Very good, beta. So immunoglobulin, yes, IgG is the only one immunoglobulin which will crosses the placenta. Well done, beta. Okay, which immunoglobulin we also call as the big immunoglobulin or the macro immunoglobulin? Yes, or the which immunoglobulin size is very big? Yes, that's the IgM. Okay, the big immunoglobulin. Very well done, beta. Well done. So all the golden points on the immunoglobulin we have already discussed, and all the among all the immunoglobulin E, that is the IgE is the immunoglobulin which will increase in the allergic conditions. Okay, and histamine is also a chemical mediator which will increase in the allergies. Okay, extrinsic causes means asthma happening due to the external allergy, where the immunoglobulin E and histamine will increase in the asthma. Okay, then in the intrinsic causes we have discussed, it happens due to the other lung diseases, or it happens due to the genetic problem in the particular person. Okay, so where the immunoglobulin E will be normal and histamine will be normal in the intrinsic causes of the asthma. So if the patient is having the intrinsic asthma, it will worsens with the age, and if the patient is having the extrinsic asthma, it will recovers with the age. Okay, so very important to remember the difference between the causes of the intrinsic and extrinsic. Okay, in the diagnosis we have studied the PEER, that is the peak expiratory flow rate. So in the peak expiratory flow rate, so it will decrease because airway will get obstruct here and patient is unable to exhale the complete air. So the peak expiratory flow rate will be decreased here. Okay, so during the asthma attack. Okay, in normal situation there is no any reduce in the peak expiratory flow rate. Okay, so peak expiratory flow rate only will decrease during the asthma attack. Okay, so in the spirometry, in the pulmonary function test, when we will check that one, FEV1 means a forced expiratory air or the forced expiratory volume in the 1 second. Okay, so that one it will be decreasing less than 70. Okay, the ratio will be FeV1 divided by the functional vital capacity of the lungs. So here this is also ratio will be getting less than 70. The question have been asked in your exam. So in the asthma, how much is the ratio in the pulmonary function test? That is the less than 70%. Okay, so similarly I told one word to you people, this asthma is in the reversible condition. Why? Because FeV1 is decreasing in the asthma, and whenever I will give the bronchodilator, so that time it will comes to the normal or 14%, sorry, 12% of the FeV1 will increase here. Okay, so that is the, I told that it is on the airway, not complete or airway obstruction or the not a irreversible airway obstruction. It is on the reversible airway obstruction. Okay, so these are the golden points we have discussed. And the most common triggering factor in India is the household dust. Okay, so very important. And asthma can happen due to the allergens like dust, pollen grains, and the pets. Okay, so then the infections like upper respiratory and lower respiratory viral infections increases the risk of the asthma. Okay, so along with that, we have discussed all other risk factors also. And the one golden point I told, the NSAIDs like aspirin is contraindicated in the asthma. Oh, beta. So do remember the very important golden point. NSAIDs like aspirin, which is contraindicated in the asthma. Why? Because these NSAIDs, we call this one as in the COX inhibitors. Okay, there is a cyclooxygenase inhibitor. So it inhibits the COX and it stimulates there is the leucooxygenase. Okay, so when is the leucooxygenase is stimulating, okay, that time the leukotrienes will increase. Whenever there is an increase in the leukotrienes, so these leukotrienes will cause the airway inflammation. So again, there is the increased risk of the asthma is there in the a patient with NSAID. So don't give NSAIDs like aspirin in the patient with asthma. And along with this one, the beta blockers also will be not given in the patient with asthma. So why beta blockers will not be given in the patient with asthma? Beta agonist drugs like salbutamol, salmeterol, terbutaline. Okay, so these drugs are stimulating the beta receptors and dilating the bronchi. So those called as the beta agonist. So in the beta agonist, we will use a short acting beta agonist drugs, that is the salbutamol, salmeterol, okay, for dilating the bronchi. And beta blockers, all the lols, okay, propanolol, sotalol, timolol, okay. So all the lol drugs are called as the beta blockers. These beta blockers, it will blocks the beta receptor, and it will blocking the beta receptor means there is no any stimulation to the beta receptors. So no stimulation to beta receptor means bronchi will not get dilated. So bronchi will get constrict here. So that is the reason the beta blockers are contraindicated in the asthma, and the NSAID are contraindicated in the asthma. You may get any one question among these, or you may get both of the question in your exam. Concept is important than the questions, because the concept help you to eliminate the wrong option, and concept help you to choose the correct answer, and you are choosing the correct answer, you are the champion in the Norcet 9. Okay, so very important, do remember the very important conditions. Okay, so these things we have discussed in the last session. So next come to the today's session point. Okay, all the golden point chanting is almost over on the basics of the asthma. Now I will go somewhat advanced, because in this particular Norcet there is in the Jipmer post also there, so don't expect the single liners in the this Norcet. Okay, yes, there may be a chance of the at least 20 to like 15 to 25 questions may arise just on the situation based, practical based, and the questions may comes on your exams with a scenario based. Okay, so I will create a scenario in the every situation, and I will penetrate in your mind the all the scenarios, so you can easily crack the exam. Okay, so yes, I told this particular classical symptoms of asthma, that is the wheezing. Okay, so comes to the clinical symptoms of the asthma, where the wheezing is happening. Okay, so that is during the exhalation or the expiratory wheezing we will say. Then the chest tightness will happens, and the cup, especially at the night it will happens, and difficulty in the breathing, that is the dyspnea will happens. Okay, so these are the classical symptoms of the asthma, especially the wheezing many time asked. Okay, so whenever the in your question you will get the word wheezing, you always think about the examiner is trying to ask question related to the asthma attack. Okay, so due to the air entry and air is not getting out, so that time the air will fill in the chest only, and chest tightness the patient will feel here. Okay, so along with that the cough will be there, and especially at the night, and the dyspnea, difficulty in the breathing will be there in the asthma. Okay, so try to understand this case scenario of the severe asthma. Okay, so whenever we will assessing the patient, if the following symptoms we are finding means, so that is the classical indication of the severe asthma. Beta, on examination, patient is tachypneic, means his respiratory rate is more than 22, and he is using the accessory muscles. So for normal respiration, the main muscle we will use is the diaphragm. The main muscle of the respiration is the diaphragm. Okay, so that is mainly we will use. Okay, if the patient is using the sternocleidomastoid muscle, or if the patient is using the intercostal muscle for the breathing, so that is what we call the use of the extra muscles or the use of the accessory muscles. So when the patient will use the accessory muscles, when the normal breathing is not possible, he is trying to breathe normally by using the extra muscles. So that is a compensatory mechanism by the respiratory system, where the extra muscles or the accessory muscles if the patient is using for the breathing, okay, he is taking inspiration and this sternocleidomastoid muscle is prominent, and there is in the intercostal retractions, okay, in between the two like ribs. So there is in the muscle movement, okay, there is the intercostal retractions is there, okay. So in this particular situation, tachypneic accessory muscles use and patient is unable to speak the full sentence. He is the monotonous, okay. So whatever he wants to tell, he is telling in the single word. Beta, the scenario is important. Do focus. Please do focus here, okay. So patient is unable to speak completely, okay, unable to speak a full words. He is speaking the monotonous word, okay. So the single words he is speaking, and he is just is completely like silent on the auscultation because of the air trapping, okay, and his SpO2 is 85%. So this is the case of the scenario of the severe asthma. So criteria is the to say the severe asthma, the respiratory rate will be more than 22, okay. In some book it's given 24, so you consider the basic according to Indian standard, that is the more than 22 breaths per minute is the tachypneic conditions, okay, and the patient is using the extra muscles or the accessory muscles for the breathing, and he is unable to speak the full sentence, that is the monotonous word is there, and the chest on the auscultation is silent, SpO2 is less than 91 percentage, okay. So saturation of the oxygen is less than 91 percentage. So this all clinical symptom classically indicating the patient is having the severe asthma. So how to treat the severe asthma? You have to give the IV steroid directly, that is the injection methylprednisone, okay, and we have to give the inhalational short acting beta agonist, so in order to dilate the bronchi, along with the oxygen we have to give here to the patient, okay. Very important to remember the first scenario, right? So severe asthma scenario is like monotonous word, patient is unable to speak complete sentence, and the use of the accessory muscles like intercostal muscles and the sternocleidomastoid muscles, okay. So along with that, the patient is having the a very important tachypnea and saturation is less than 91 percentage. So these are the classical symptoms where the examiner will give in your questions in the exams, okay. So here is the next scenario in front of you, the case number 2, okay. So during the asthma attack, suddenly the absent of the wheezing is there. So will you happy or will you get sad here? So consider you are a nursing officer working in the AIMS emergency department, and suddenly from a home the patient came and he is sitting on the bed, okay. So he is sitting on the bed, and whenever he will auscultate the patient, so that time you will get the wheezing sound, okay. So you will get the wheezing sound, and you are waiting for a 2-3 minutes and you are taking care of the other patients. Now this patient which came with the complaints of the wheezing, suddenly wheezing get stops here. So will you get happy or will you get sad? Yes, beta, sir, asthma happening, wheezing happening, wheezing stop, asthma stop. No, not like this. Beta, wheezing, asthma happening, because of that wheezing is happening. If wheezing suddenly gets stopped, it indicates the airway is completely blocked, so there is no air entry and there is no air exhalation, okay. So it means that during the asthma attack, suddenly absent of the wheezing, it indicates yes, the slowly wheezing is getting subside, means the bronchi is getting dilation, and like the patient is recovering. The word sudden absent of the wheezing, it indicates the bronchospasm. What it indicates? It indicates the bronchospasm, okay. And here the priority nursing responsibility, the PNI priority nursing responsibility goes to the establish the airway, and we will intubate the patient immediately, okay. So we will intubate the patient immediately, very important. So whenever patient with asthma suddenly wheezing stop, means don't be happy. It is in the sad situations where the airway of the patient is block. Okay, so if you are not paying attention to take care of the patient will be completely blocked here. Okay, so hope you got understand. Sir, what is the brittle asthma? Brittle asthma is the asthma where the patient comes to the hospital. We have given the all the high dose of the steroid. Still, the inflammation of the airway is not reducing. Okay, severe asthma attack where it is not reduced with a high dose of the steroid. So we call that one as the brittle asthma. In the brittle asthma, we have to use this drug adrenaline or the epinephrine with the ratio of the 1:1000. That is the by the route of the intradermal route we will give. Do you remember the very important condition on the asthma? Okay, so that is the what is brittle asthma, sir? Brittle asthma is a situation where the severe asthma attack have been happened and which is not relieved by the high dose of the steroid. That is the brittle asthma, where the injection adrenaline 1:1000 ratio intradermal route we are giving in the brittle asthma. Then comes to the next point, that is the most common complication of the asthma, that is the emphysema. Okay, so what is the emphysema? Our asinus means the last respiratory bronchioles and the alveolar ducts and the alveoli, it will get abnormally get dilate and air entry will happens, air will not go back. Okay, so asthma is emphysema is in the situations where the sinus lost its elasticity and the air tapping will happen. Okay, so what's the emphysema stands? Emphysema stands for a word that is on the air trapping. Okay, so air is getting trapping inside the lungs only. Okay, so this is the most common complication of the asthma. If someone is asking the question, which of the following is the most common complication of the asthma? So what is your answer? What is your answer, beta? Your answer should be emphysema and beta blockers I told, which is contraindicated in the asthma. Why? Because it will causes the bronchospasm. The situation scenario already explained. Okay. So next treatment of choice of the asthma. So we will go for the short acting beta agonist. What is the SABA stands here? The SABA, which I have mentioned here. What is the SABA stands here? The SABA stands here is the short acting beta agonist, plus we will give the steroids. Okay, we will give the inhalational steroids. Inhalational steroids we will give along with the particular word SABA. Okay, a particular SABA. Okay, so we will not go for the LABA here. Okay, so what is the LABA, sir? Long acting beta agonist. Okay, so LABA is for the chronic maintenance. Okay, for the long term maintenance, like in the COPD, we will go for the LABA. Okay, so in the COPD, chronic obstructive pulmonary disease, like long term management, we will go for the long acting beta agonist. For the asthma attack, we will go for the short acting beta agonist, and the SABA is the drug of choice we will use in the treatment of the asthma. So especially salbutamol and albuterol are the drugs we are using here. Okay, so then the which monoclonal antibody we will use in the asthma? So this is a recent question which have been asked in your INSCT and other exams. Okay, especially 2 to 3 times asked question. So the monoclonal antibody which we are using in the treatment of the asthma is the omalizumab. Okay, so what is that one? So that is the omalizumab. Remember. Okay, so that is the omalizumab is the monoclonal antibody, so which we are using in the management of the asthma. So it will reduce us the IgE induced inflammatory reactions, and it will reduce the autoimmune reactions, and it will reduce the or suppresses the sudden allergic reactions of the airway. So that is the where the omalizumab is the used as in the monoclonal antibody in the management of the asthma. Do remember the very important point. Okay, so which positions we need to give during the asthma? So that is the high polar positions or the upright positions. Whenever the patient will comes to emergency department, the first thing we have to do is the keep the patient in the high polar positions or the upright positions, so it will help her to expand the lung and breathe properly. Okay, so that is the very very important thing. Then comes to the word status asthmaticus. So this is the emergency of the asthma. Okay, this is the emergency situations. If you are not treating properly, the patient will die here. Okay, so that is the status asthmatics. Suddenly severe attack of the asthma is happening and we are giving all the standard bronchodilator therapy. The asthma is not subsiding. Okay, and it is persisting more than 24 hours. Okay, it is continuously happening more than 24 hours, and as the time progressing severity of the asthma is increasing. So that is the rapidly worsening and persisting more than 24 hours sudden severe attack of the asthma, where it is not responding to the bronchodilator therapy. Okay, that is what we call the status asthmaticus, and which can lead to the respiratory failure and death of the patient also if we are not treating. Okay, so sir, how to manage the status asthmatic? What is the standard protocol, sir? What is the standard protocol to handle this particular emergency situation of the airway? So that is the status asthmatic. So first thing what we have to do is to upright positions we will give, and we will start the oxygen to the patient here. Okay, so first thing what we have to do is we will give the upright position and we will start the oxygen, and the second thing we will give is the nebulization with the SABA, that is the short acting beta agonist, especially the salbutamol nebulization we will give, and we will repeat the nebulization for the every 20 minutes one time. We will repeat the salbutamol nebulations. Along with that, we will give the ipratropium bromide. Okay, so this is the anticholinergic drugs. So it is on the atropine derivative, where it will help for the bronchodilation. Okay, so then we will, if the patient comes within 1 hour of the asthma attack, so we will give the IV hydrocortisone also. Okay, so within 1 hour. Then if the no improvements, okay, so we have given the nebulations with the short acting beta agonist, and we are repeating every 20 minutes, and we are giving the ipratropium bromide nebulization, and IV hydrocortisone also I am giving. Okay, so if it is not improving, so then the refractory asthma, or the asthma which is not responding to the hydrocortisone, steroid, and the bronchodilators, means the last final options we have here is the injection magnesium sulfate we will give for the bronchodilations in a case of the status asthmaticus. So do remember the very important word. Okay, so please do remember the very important word here, the injection magnesium sulfate for the situation called as the status asthma. Okay, status asthmaticus emergency situations. If even after giving the SABA and even after giving the IV hydrocortisone, the patient is not responding and the patient airway is not clearing, so that is the very important. We will go for the refractory status asthmaticus. So I will use the IV magnesium sulfate for the purpose of the bronchodilation. Okay, so that is a very important question you have to understand here. Okay, so here is the next question in front of you. So please do read the question and try to give the best answer better. So within like 15 to 20 minutes, complete disease condition of the asthma and its golden points I have covered. And asthma is the very important topic for your exam, and every alternative Norcet exam there is one question or the two questions which repeatedly asked from the asthma. So it is now completely clear to every one of you. Okay, so we have discussed the severe asthma and how to manage that one. We have discussed the clinical manifestation of the severe asthma and how to identify that one, and we have discussed the status asthmaticus, and we have discussed the how to give the medications in the asthma patient, and we have discussed the classical symptoms of the asthma, and we have discussed the most common complication emphysema of the asthma, and all the points that is necessary for the asthma I have given in the rapid revision session. So now the next question is in front of you. So please do mention the correct answer in the comment box. Okay, so I'm waiting for your response. So don't get late. Okay, do read the question. Simple questions are there, and whatever the concept I am building in behind the question, so that is your key for the getting the success, and that is the key for the getting the good rank in the exams. Okay, so believe in the concept. So concept will makes you a champion, right? Yes, so please do read the question, and I want everyone's response in the comment box. Yes, the two major conditions that falls under the COPD are option A, asthma and bronchitis, option B, a chronic bronchitis and emphysema, option C, bronchitis and fibrosis, option D, pneumonia and asthma. Yes, which one is the correct answer? A two major condition that falls under the COPD is. Well done, beta. Well done. So almost all you people given the correct answer. That is the chronic bronchitis and the emphysema are the two very important situations which falls under the COPD. What is the meaning of the COPD, sir? It is in the chronic obstructive pulmonary disease where the patient airway will be obstructed for the chronic time, and it will be irreversible situation. Okay, so it is in the irreversible situation. It is irreversible situation of the airway. Where the asthma, what we have studied just now, so that is the reversible situation of the airway. Okay, so let me quickly revise all the golden points on the COPD. Better, in the golden points of the COPD, the two very important thing we will study under COPD is the chronic bronchitis and the emphysema. Sir, what is the chronic bronchitis? I will tell, don't worry. What is the emphysema and what are the questions will come on the emphysema? Quickly we will revise in this particular session, so it will be helpful for you all. Okay, so chronic bronchitis and emphysema is the both together we will call as the COPD, that is the chronic obstructive pulmonary disease. Okay, and here the FEV1 forced expiratory volume in 1 second is to functional vital capacity of the lung ratio is always less than 70 in the COPD also. In the asthma also, it is less than 70%. Okay, so we can say it is in the less than 0.70, or we can say this one is in the less than 70%. Both are the same. Okay, so don't feel difference. Okay, both are same here. Okay, so then comes to the gold classification of the COPD. So what is meaning of the gold classification here, beta? So for the classifying the chronic obstructive lung diseases, so there is in the global initiative for the chronic obstructive lung disease. Okay, so that is for the global initiative. Okay, so G stands for the global initiative, O stands for the obstructive, L stands as the lungs, and D stands as the disease. Okay, so this is the gold classification which is there for the classification of the obstructive lung disease. Okay, so do remember the which classification we will use to classify the obstructive lung disease. Yes, which classification we are using to classify the obstructive lung disease? That is the gold classification. That is the global initiative for the chronic obstructive lung disease. Okay, so based on this one we will classify the chronic obstructive lung disease. Beta, after giving the bronchodilator therapy, if FEV1 means a forced expiratory volume in 1 second, so that is in 1 second how much amount of the air I have exhaled out of my lung. Okay, that is what we call the forced expiratory volume in the 1 second after giving the bronchodilator. If it is more than or equal to the 80 means that is the mild COPD. Okay, if it is between the 50 to 80% means there is the moderate COPD. If it is between the 50 to 30 means 30 to 50% means so there is a severe COPD. And if it's getting less than 30 means so that is our severe case of the chronic obstructive pulmonary disease. Yes, so please do remember the gold classification of the COPD. It may strike in your exam. It is based on the FEV1. Okay, so that is the forced expiratory volume in the 1 second. So you have taken 100% of the air, and in 1 second you are like after giving the bronchodilators, you are exhaling the more than 80%, means there is a mild COPD. Okay, so if you are exhaling the 50 to 80% means there is a moderate COPD. If you are exhaling the 30 to 50% in the 1 second means there is the severe COPD, and you are unable to exhale more than 30%. You are exhaling only less than 30% means so that is the case of the severe COPD. Very, very important. Okay, so here is the most common cause or the most common risk factor for the COPD is smoking. Most common risk factor for the emphysema is the smoking. Most common risk factor for the chronic bronchitis is the smoking. So please do remember the very, very important word here. If the examiner is asking a question that is the most common cause for the COPD, emphysema, chronic bronchitis, only one answer, that is the smoking. Smoking is the most common cause for the chronic obstructive pulmonary disease, emphysema, chronic bronchitis. Okay, so in the COPD, okay, so there will be erythrocytosis. Why there is in the erythrocytosis in the COPD? Can anyone want to answer for this question? Why there is in the erythrocytosis? Okay, there is the increased red blood cells in the COPD. Why? This question have been asked multiple times, so I want to clear your concept behind this one, so it will be very much helpful for you all. Okay, yes. In the chronic obstructive pulmonary disease, I told it is on the chronic condition. Means chronically means a days together, months together, year together, there is an obstruction in the airway. Means a days together, months together, years together, there is the low oxygen supply to the blood. Right? So whenever there is the low oxygen concentrated blood, it will go to the kidney. So kidney, what it will thinks? The oxygen is carrying less because of the low RBC. It will think like this. Actual problem is there is the blockage in the respiratory or air entry. So because of that, there is the low oxygen concentration in the blood. but kidney will think this particular situation of the low oxygen is happening due to the less RBC. So kidney will start to release the hormone called as the erythropoietin. So erythropoietin is the hormone which is responsible for the production of the erythrocytes, okay, or we can say the red blood cells. Whenever there is a blood with low oxygen concentration, it will go to the kidney, and kidney will start to release the erythropoietin hormone. So do remember the golden word, from where the erythropoietin hormone will be released. From the kidney, the erythropoietin hormone will be released, and so erythropoietin hormone is the hormone which is responsible for the production of the erythrocytes or the red blood cells. Okay, so due to the chronic hypoxia and due to the chronic hypoxic blood supply to the kidney, so kidney will release the erythropoietin, and erythropoietin will causes the erythropoiesis. So that is the in the COPD, which blood cell will be raised? Your multiple choice question in your exam. So as a nursing officer, you are taking care of the patient of the COPD in the general ward. Okay, so as an officer, you got the CBC report in your hand. So that is the complete blood count reports you have got in your hand. So which cells you looks for a rise in value in the case of the COPD is your question. Okay, so this is our situation question. Option E, so there may be in the thrombocytosis, there may be in the erythrocytosis, or there may be in the leukocytosis, or there may be in the leukocytopenia. So what will be your answer? Your answer should be erythrocytosis. Why? Because in the COPD, a chronic hypoxic blood is going to the kidney, and kidney is secreting excessive erythropoietin, and erythropoietin is producing the erythrocytosis, okay, which is producing the erythrocytes, that is the RBC. So RBC number will be increased in the case of this COPD. Very important and very basic concept, so that is not much necessary for your exams. Okay, so do remember the very important point. Okay, so that is the reason whenever the patient with the chronic kidney disease CKD, okay, it will comes to you, so always assess for the anemia. Why? Because I told kidney is the organ which is responsible for the production of the erythropoietin. Where in the CKD or the chronic kidney disease, the kidney is damaged, means there is no erythropoietin. There is no erythropoietin means there is no RBC. There is no RBC means the patient will land into a situation called as the anemia. Okay, so in the CKD, which red blood which cells will get decreases? In the chronic kidney disease, red blood cell will get decreases. Okay, so in other situations, what we call in the COPD, which cell will increases? In the COPD, erythrocytosis will increases. Okay, so that is the RBC will increases, which causes the increased number of the red blood cells. So hope the concept is clear. Yes. So here is the next very important golden point on the COPD. But in the COPD, which type of the respiratory failures happens? So in the last Norcet, there was a question called as the hypercapnic respiratory failure. Okay, and there was a situation on the hypercapnic respiratory failure, and they have asked the cause for the respiratory failure. Okay, so there where they have given the PaCO2 is more and the PaO2 is less. Okay, so the PaCO2 is more means there is the situation or the case of the hypercapnic respiratory failure. Okay, in the hypercapnic respiratory failure, so which happens due to the COPD, very important. Okay, so COPD is a common cause for the type 2 respiratory failure or the type 2 respiratory failure, or we can say the hypercapnic respiratory failure. So this is your last Norcet question. Okay, this is your last Norcet question, very important. Please do remember a very important thing. Okay, in the COPD, PaO2 decrease or like normal, but PaCO2 will increase. Okay, so that is the reason this type 2 respiratory failure, we also call this one as in the hypercapnic respiratory failure. Okay, so what we call this one as in the hypercapnic respiratory failure. Very important. Please do remember the concept. Okay, so next is the drug of choice in the COPD is the tiotropium. This is a very important anticholinergics. Okay, so which is having the ability to increase the sympathetic nervous system. So sympathetic nervous system is increasing means the bronchus will get dilate. Okay, so this one we can use in the emergency situation also, or in case of the chronic maintenance also, tiotropium we will give. Okay, so then the treatment of choice for the COPD is the oxygen beta. If someone is asking the drug of choice for the COPD is the tiotropium bromide. If someone is asking the treatment or the best treatment of the choice for the COPD is the oxygen, because in the COPD, what happens? There is in the accumulation of the carbon dioxide inside the body. Okay, so there is in the carbon dioxide is getting accumulating, means which will cause the hypercapnic respiratory failure. So that is the reason the life-saving treatment or the treatment of choice or the life saver of COPD patient is the oxygen. So at what rate we will give the oxygen to the a patient with COPD? We will give at the 2 liter per minute only. Okay. So for how much duration? So that is the 16 to 20 hours in one day we will administer the CO2 oxygen. So that is only at the rate of the 2 liter per minute. Why, sir? Here means, so this is the condition of the chronic obstructive pulmonary disease. If I am giving a 6 liter, 8 liter per minute, means patient will create the dependency and the patient pneumatic center or the respiratory regulatory center, so which will be get stimulated by the carbon dioxide. So if I am giving the continuous oxygen, means so oxygen will increase in the a particular body, and that particular respiratory regulatory center which requires the carbon dioxide to get stimulated, it will not get stimulated because I am giving the oxygen continuously, so carbon dioxide will be reduced. So no carbon dioxide means no respiratory center stimulation. No respiratory center stimulation means the patient will not spontaneously take activity to get breathe. Okay, so in order to avoid that one, I will give only 2 liter per minute of the oxygen, so the like amount of the carbon dioxide will be available in the blood, and that carbon dioxide it will stimulate the respiratory regulatory center, or what we can say the pneumatic center, and that is the where situation the patient is not completely depend on the external oxygen, and the patient will keeps on spontaneously breathe out the things. So that is the very important why we will give the only 2 liter per minute of the oxygen. Okay, so which device we will use to administer the oxygen in the patient with the COPD? Yes, beta option में दोनों है situation where you will get the nasal prongs also or the nasal cannula also as an option, or the blue color venturi mask also in the option. So which one we will choose? A best device for the management of the COPD is option A, blue color venturi mask, and in the option B you are getting the nasal cannula, or we can say the nasal catheter. Okay, so which one will be your answer? Better don't go for the blue color venturi mask, because this is a patient with a chronic situation, right? Patient can't carry the oxygen mask everywhere he is going, but he can wear the nasal prongs. So the best for the chronic situation is the nasal prongs, and in the home management also the patient can easily wear the nasal prongs, and after wearing the nasal prongs the patient can eat, he can drink, he can talk. Okay, so that is the independence. So in the COPD means in the chronic situation, years together, like months together, where we will can't advise for the mask continuously. In the emergency situations, we can use the for the specific delivery of the oxygen in a patient with COPD, we will use the blue color venturi mask. Okay, which venturi mask is best means blue venturi mask is best, but the preferred best oxygen delivery system in COPD is the our first answer goes to the nasal cannula. Okay, so hope it is clear to every one of you, right? So concept is important. Here is the next, chronic bronchitis. So what is the criteria to diagnose the chronic bronchitis? Better in the last 2 years, patient is having the cough with sputum, so that is more than or equal to 3 months. In the 2 years, 3 months, patient is having the cough and sputum, so this is the case of the chronic bronchitis. So the most common risk factor I told in the COPD also smoking, emphysema also smoking, and the chronic bronchitis also smoking. So the most common risk factor for the chronic bronchitis is the smoking. And in the bronchitis or in the chronic bronchitis, we will get a blue bladders. So what you mean by the blue bladders, sir? Blue bladder means the patient body will get blue because of the patient with the chronic bronchitis. So there is the excessive accumulation of the carbon dioxide inside the body, so the body may enter into the sinuses. So the scenario, the situation you have to understand here, in the chronic bronchitis we will get the blue bladders because of the increased carbon dioxide, or because of the increased partial pressure of the carbon dioxide. Why? Because patient will smoke, so that smoke will damage the all the mucus like clearing cells. Okay, so in our respiratory tract, we have the ciliary. Okay, that in the respiratory tract it is made up of the pseudo stratified ciliated columnar epithelium. Okay, so it is in the it looks like in the double layer of the epithelium, but it is only a single layer of the epithelium, so we call it one as the pseudo stratified ciliated columnar epithelium. It is having the hair-like structure, so we call this one as the cilia. Okay, so this cilia, whenever some mucus will comes, it will push it out of the respiratory tract. Whenever some dust will come, it will put out of the respiratory tract. Okay, so in the chronic bronchitis, so due to the smoking, the patient is have burned all the cilia. Okay, so all the cilia of the patient with the chronic bronchitis have been damaged here. Okay, there is no cilia to get push the dust and sputum out of the respiratory tract. So dust, sputum, everything will get accumulated. The chronic bronchi inflammation will happen, and it will get start accumulating the carbon dioxide. Okay, so that patient makes the blue in color. So that is the blue bladders we will see in the patient with the chronic bronchitis. Very, very important. Please do understand. Okay, and the treatment what we are giving in the patient with the chronic bronchitis, that is the our very, very important. Oxygen is the treatment of choice for the chronic bronchitis we have to give, and we will treat the underlying respiratory infections by inducing the antibiotics. Okay, hope it is clear to everyone, right? And then the next disease condition under COPD what we are studying, that's the emphysema we are studying. Okay, so in the emphysema I will again revise all the golden points on the emphysema, and what is the emphysema also I will tell. Don't worry about that one. So just try to focus on the concept what I'm explaining, and nothing will come in your exam except these things. Okay, so just give me a second, I will have some water. Yes, so in the emphysema, the most common cause of the emphysema, yes, again the most common risk factor or the most common cause is the smoking. Already we have discussed. Okay, so this smoking, what it will do? So due to the repeated chronic smoking, it will cause the deficiency of the alpha-1 antitrypsin. So this alpha-1 antitrypsin is a protein which is very much necessary for maintaining the elasticity of our acinus. Sir, what is acinus, sir? Acinus is this particular respiratory bronchiole and this alveolar duct and this alveolar sac. Together, I will call this one as the acinus. Okay, so what is acinus? Acinus is the respiratory bronchioles, alveolar duct, and the alveolar sac. So together, I will call this one as the acinus. Okay, so this acinus, where it will get lost its elasticity. So normal condition, whenever the air will comes inside, in the normal condition, okay, so whenever the air will comes inside, okay, so it will goes out, because it is having the elasticity. When it will get expand, it will get contract also. So because it is having the elasticity. But in the case of the emphysema, what happens? So due to the deficiency of the alpha-1 antitrypsin, so it will lose its elasticity. It will lose its like contracting function. Okay, so that is what we call, whatever the air it will come inside. Okay, so it will get trapped inside only. So if the air trapping inside, we call that one as the situation called as the emphysema. Okay, so what is emphysema? Emphysema is the air trapping due to the loss of the elasticity of the respiratory bronchioles, alveolar duct, and alveolar sac, where the abnormal dilation of our acinus will happen due to the air trapping. And air is trapping means, yes, the air is keep on increasing the respiratory circumference. Okay, air is coming but it is not going back, means so the air, like the patient respiratory system will be get hyperinflated. Okay, so in the X-ray we will get the hyperinflated lungs, and in the X-ray the anterior posterior diameter of the chest will also get increased because of the the air is getting trapped inside only, the air is not coming out. So the anterior posterior diameter of the chest will increase, and the lungs looks like a hyperinflated. Okay, and do remember the very important word in the X-ray of the patient. You are getting the hyperinflated lung, and anterior posterior diameter of the chest is increased, and the diaphragm is flat. Okay, diaphragm is usually this shape. Okay, so if this particular diaphragm, that's the main muscle of the respiration, is getting flat like this, so this is a situation which makes the chest looks like a barrel. Okay, so in the a very important situation in emphysema, we will get the barrel shaped chest. Very important golden point for your upcoming exam. Emphysema, most common cause for the smoking, and it happens due to the alpha 1 antitrypsin deficiency, and that is responsible for maintaining the elasticity. Where the alpha 1 antitrypsin is deficient, means elasticity is lost, and whichever the air will get enters inside, it will not comes out. So it will causes the air to get trapped inside, the air trapping inside the sinus only, and it will like in order to bring it out. Okay, so we need to educate the patient to use the pursed lip breathing. Okay, so very important. Why the patient should use the pursed lip breathing? The question will be there in your exam. Okay, so what you have to educate to the patient of the COPD. In a patient with COPD or emphysema, we will educate for the two breathing techniques. One is for the pursed lip breathing technique. Another one is for the abdominal breathing. Okay, sir, what is the use of the pursed lip breathing technique? We will advise the patient to slowly exhale the air by making the pursed lip breathing. Okay, it's like this. So slowly patient is exhaling means, first thing, alveoli will not get collapsed. Second, very important thing, the carbon dioxide which is trapping inside, it will get exhales out. Okay, the carbon dioxide will be eliminated from the pursed lip breathing. And the third very important thing, whatever the trapped oxygen is there, which will also will come out. Okay, sir, first thing, alveoli will not get collapsed. Second thing, carbon dioxide will get eliminated. So, and whatever the trapped air is there inside, so that is also will comes outside. So patient is using the pursed lip for the breathing. Okay, so the trapped oxygen which is there inside, whatever the air entered inside, which is not coming back outside. So due to the chronic exposure of the oxygen, okay, like we are doing, so this particular lips and the surround area which will prolong time exposes for the oxygen. So the lip area which looks like pink in color, so that is what are the very area over the mouth and face also we can get a pink in color. So the pink puffers will be seen in case of the emphysema. Sir, how to remember the blue blotters and the pink puffers, sir? If we get confused in the exam, so we will not get confused in the exam. Do remember, in the emphysema we have the P, so that is the pink puffers, you remember. Okay, in the chronic bronchitis we have the B, so that is the blue bladders will be seen in the bronchitis, pink puffers will be seen in the emphysema. So please do remember the two very important golden points. Okay, so if air is getting trapping inside and it is not coming outside, okay, so air is going inside and it is not coming outside, the air trapping is happening. So this alveoli which looks like bullae, okay, so the bullae formation will happen in the case of the emphysema. Okay, so if this bullae is rupturing, so whatever the air is coming, it will leaks like this. Okay, it will leaks like this, and this air will enters into the covering area of the lungs, where the space of in between the two very important pleura. Okay, so that is the covering area we call the pleura. So we have the two pleura. One is the parietal pleura, another is the visceral pleura. Okay, so from the visceral pleura side, it will get enters into the air will get enters into the our pleural cavity. So there is then the pleural cavity which is filled with the air. We call that one as the pneumothorax. So the complication of the emphysema is the pneumothorax may happens here. Okay, so please do remember, the air is trapping means the bullae will be formation happens. Okay, so if the bullae rupture will happens in case of the emphysema, so air will enters into the pleural cavity. So if the air is entering inside the pleural cavity, it will cause the pneumothorax. Please do remember, as a complication of the emphysema, we will get the pneumothorax. Okay, so what is the management, sir? If the bullae formation happens in the emphysema, so we will do the bullectomy. Okay, so we will remove the particular bullae, or the if that particular complete lobe is filled with the which is formed with the bullae, means we will do the lobectomy also. And the treatment of choice for this one is the very important lung transplantation is the final treatment for the emphysema. There is no any other options, because this emphysema is in the irreversible condition. So where we have to go for the lung transplantation as the option. Okay, so the no role of the oxygen is there in the treatment. Why? Because the oxygen is entering and it is getting trapping inside. So in order to avoid that one, we will not give the oxygen here directly. So because the patient is having the very important case of the emphysema. So in the chronic bronchitis, the life-saving treatment is the oxygen, but in the emphysema, there is no role of the oxygen. Okay, so hope it is clear to every one of you. Okay, so this particular question just now only we have discussed, so I want everybody's response in the comment box. So please do mention your answer in the comment box. Yes, you have got a patient in your general ward. Okay, you sent the patient for the X-ray department for the X-ray, and after coming the patient, your X-ray is showing the hyperinflated lungs, and there is in the flat diaphragm is there in the X-ray. Along with that, yes, along with the flat diaphragm, along with the hyperinflated lungs, the anterior-posterior diameter of the chest is increased. Okay, so that is what we call as the barrel-shaped chest. Okay, that is what we call that one is in the a barrel-shaped chest. This barrel-shaped chest is most commonly seen in which situation? Just now only we have discussed that is the, and almost all you people have given the correct answer. That is the emphysema. Okay, sir, what is the X-ray? We will see the emphysema. In the X-ray of the emphysema, you will get a very important. There is a flat diaphragm because the air is getting trapping inside, and the lungs are very big. Lungs are hyperinflated. Okay, so lungs are overinflated or the hyperinflated. Okay, which increases the diameter of the chest. Okay, so that is the anterior posterior diameter of the chest is increased, and the diaphragm become flat here. Okay, so diaphragm is flat, lungs are hyperinflated, and the anterior posterior diameter of the chest is increased. So we call this one as the barrel chest. So this barrel chest is classically seen in case of the emphysema. Okay, so this one is seen in case of the emphysema. Okay, so very important. So please do remember the very important conditions here. Okay, so look like the normal chest. Okay, so here it is the like this. Okay, so it will be like this, means the transverse diameter is more than the anterior posterior diameter. Okay, so look at this particular second image. Okay, so where the anterior posterior diameter is more. Okay, here it is 3 centimeter, means here it will be a 6 centimeter. Okay, so anterior posterior diameter will be, just for the example purpose I am telling. Okay, so here it will be over and like a big anterior posterior diameter will happen. So that is what we call the barrel shaped chest. Okay, it will be seen in case of the very important COPD. Okay, so beta, this particular explanation what I am doing here, this will be our 5-star explanation, and this definitely have been struck in your already it have been struck in your Norcet exam, and it is there is highest chance of asking the question again in the upcoming Norcet exam. Sir, what is the question, sir? So the question is on the smoking de-addiction. Sir, why we have to study the smoking de-addiction? Beta, we have studied the 3 conditions. Okay, under the COPD we have studied the chronic bronchitis, and we have studied the emphysema. So for the both, I told the most common risk factor is the smoking. Okay, so in the management of the COPD, emphysema, or the chronic bronchitis, smoking de-addiction is the very important step. Even if we are treating a patient with the COPD, emphysema, or the chronic bronchitis, and the patient is not quitting the smoking, means there is no any meaning in the treatment. So just we can say you can go, you can smoke, and you can die. Okay, so there is no problem, right? So if the patient is ready for leaving the smoking, so we can treat this patient better, and we can improve his quality of the life. Okay, so the smoking de-addiction is very important while in the patient of the COPD. Okay, while taking care of the patient of the COPD, right? So here is the smoking de-addiction. 2 very important steps we have to understand, and 2 important word we have to focus in the exam. So first word is which thing we have to give to reduce the withdrawal symptoms or the withdrawal effect of the smoking. Patient is smoking since from the last 6 years, 7 years. Suddenly we can't stop the smoking. If you are stopping the smoking, it will increase the sign symptoms where the patient will land into the anxiety, perspiration, continuous sweating will come. Okay, so along with that, the patient will experience the lots of the different problem like constipation. Okay, so like that of the problems the patient will experience if you are suddenly stop the smoking. Okay, so in order to avoid the withdrawal symptoms, we will not stop the smoking suddenly. So we will ask them to patient to stop the smoking, but along with that we will replace the nicotine externally. Okay, so the nicotine is the substance which is there in the smoking, which will give the pleasure to the patient. So that one we will ask the patient to stop the smoking, and externally in order to reduce the withdrawal effect we are giving the nicotine. Okay, so that is the nicotine replacement therapy I will do, and here it will comes in the 2 form. One is the patch form, so nicotine patch. So I will apply it to the area where it is away from the heart, and area which is like not involved in the exercises. Okay, consider you are a gym person, you are daily going to the gym, and here in the bicep muscle you have applied the a nicotine patch. Okay, and you went to the gym and you have done the gym, so the nicotine, like the muscle involved in the gym is the increased in the heat, and the muscle which will be requiring the more metabolism, and that particular nicotine patch what we have applied, so that will be observed suddenly. Okay, so that is the reason whenever you are applying the patch, don't apply at the near the heart. Okay, so away from the heart you have to be, and wherever you are applying the patch, so that will be a free from the hair. Okay, so along with that, don't apply at the site where it is involved in the exercise or in the it is involved in the heavy activities. Okay, so along with that, we will have the chewing gum. Okay, so chewing gum also will be available as a nicotine chewing gum. Okay, so for that chewing gum, we will ask the patient to cut the chewing gum, chew the one time, and park into the buccal mucus. Okay, so this is what we call the cut, chew, and park technique we are using in a patient with a very important nicotine dependency. Okay, in the order to reduce the withdrawal symptoms. Okay, so we are giving the nicotine chewing gum means we will advise for the cut, chew, and park technique. Okay, so very important one. Along with that one, the second question in the examiner is mentioned: a patient is de-addicted from the smoke, and now he is getting the craving, or there is highest chance of the relapse of the situation. Okay, so we have educated the patient, and we have advised the patient to not to get smoke, and he is ready for the leaving the smoking, and now we have given the nicotine replacement therapy in order to reduce the withdrawal symptoms. Okay, so after that the patient is getting he is getting the craving of the smoking, again you want to smoke. So in order to prevent that the relapse of the smoking, we will give the a drug of choice. Okay, so in order to reduce or decrease the craving, okay, in order to reduce or decrease the craving, and in order to reverse prevention of the relapses, so there is a drug we call as on the drug of choice for the our very important situation called as on the craving prevention and the relapse prevention in the nicotine dependency or in the smoking. So with the drug of choice is the varnicellin. Okay, so the varnicellin is the drug of choice. Okay, and second drug which one we can use? We can use the bupropion also. Okay, so but the first drug and the best drug to prevent the relapse and to reduce the craving of the patient with the smoking. Okay, so that is which drug we are using, that is the varnicellin is using to reduce the craving and the relapse prevention, and to reduce the withdrawal symptoms we will use the nicotine replacement therapy. Okay, so that is the very important technique you have to understand, right? So which position we will give in a patient with a COPD? Already 1000 times asked question in your exam. Okay, so the best position while taking care of patient with COPD is the orthopneic position or the high polar positions with leaning forward. Many time asked questions, or we can say this one is in the tripod position also. So look at this image here. Here the patient is sitting. Okay, so here we have kept the cardiac table. Okay, on this cardiac table we have kept the pillow. Upright positions we have given, and we have asked the patient to lean forward. Okay, lean forward on the cardiac table. It will allow the patient to, okay, so exhale the maximum carbon dioxide, and it will allow the patient to inhale the most of the oxygen. Okay, so that is the orthopneic positions, or we can say this one is in the tripod position also. Okay, or we can say the high polar positions with the leaning forward. Okay, so that is the very important position we will give in the patient with the COPD. Okay, so the next question is here in front of you: which techniques of the breathing we will advise to the patient with the COPD? Better we will advise the pursed lip breathing. Okay, so pursed lip breathing is advised to eliminate maximum carbon dioxide elimination, maximum CO2 elimination. And another very important reason is it will not allow the alveoli to collapse. Okay, so not allows alveoli to get collapse. Okay, there is no any alveolar collapse, and there is no any like trapping of the air if you are using the pursed lip breathing. Okay, so along with that we will advise the patient to diaphragmatic breathing or the abdominal breathing, where we will advise the patient to more use the abdominal muscles also in order to diaphragm. Sorry. So that is the diaphragmatic breathing, where we will advise the patient to more use of the diaphragm. Okay, so it will reduce the use of the accessory muscles. Okay, this purpose of the diaphragmatic breathing is to decrease the use of accessory muscles. So please do remember the word. Okay. So next, which diet we will give in a patient with COPD? We will give the high calorie diet, high protein diet, and a small and frequent diet. Why? Because why we have to give the high calorie diet, high protein diet, and the small and frequent diet? Why? Because the patient airway is obstructed. He need the more energy to inhale the air. Okay, he need the energy to exhale the air also. Okay, why? Because the airway is obstructed here. Okay, so that is the reason we will give the somewhat extra calories, somewhat extra protein, and somewhat extra energy to the patient to for its proper breathing. Okay, so because the patient will can't feel fatigue for the breathing. Okay, and the small and frequent meal we will advise in order to reduce the discomfort while the deep breathings. Okay, so very important one, and we will advise the patient to increase the fluid. Okay, this one is a multiple time asked question. So why we will advise the patient to increase the fluid in the case of the COPD? Yes, why we will advise to increase the fluid in the case of the COPD? Why? Because the patient is taking excessive fluid, so the mucus will get thin. Okay, so mucus is getting thin means it will comes out easily. Okay, so it will comes out easily out of the respiratory tract, it will comes out. Okay, so that is the reason we will advise the patient with the COPD to increase the fluid intake. Okay, so then comes to the oxygen in a patient with the COPD. So best device is the a nasal cannula is the first best answer. Why? Because this is best for the long term use. Okay, so if we are the patient is we are giving only 2 liter per minute. Okay, so only 2 liter per minute we are giving. Okay, so that is for the chronic time, not for the one day 2 days. We are giving for this one for the 2 months 3 months. Okay, or the year together also. Okay, for that reason the mask is not good, because if the patient is having the mask means he will get difficulty in eating, talking. Okay, he will get the difficulty in the like there will be a wearing also, there will be a problem. But the nasal cannula he can wear easily. Okay, so that's the 2 liter per minute for the duration of the long term we are giving means the best priority answer goes to nasal cannula. And if the examiner is asking which venturi mask is best, better we have the different type of the venturi mask. So among all the venturi mask, which venturi mask is best means, so that is the blue color venturi mask is best for the COPD patient. Okay, overall best device is the nasal cannula, and the best venturi mask is the blue color venturi mask. Okay, so because it will deliver the precise amount of the oxygen, or it will deliver the accurate level of the oxygen, that's the 2 liter per minute. Okay, so very important, that is the reason the blue color of the venturi mask is best prepared in the patient with the COPD. Okay, hope it is clear to every one of you. And here the golden point chanting on the COPD completes, and all the important points, necessary points, and on the COPD I have covered to every one of you. Okay, so in the next session we will discuss the very important, okay, questions and concept on the ARDS. Okay, so ARDS is the very important thing. We will discuss this particular session. Okay, so I told you people to I will hit the at least 3 classes per day. So maximum I will hit 2 classes, because you people will not get bored, because one time loading is not possible. So I will push the content which is in a break and in a particular style, so it will be helpful for you people to get to understand the thing. And the ARDS also most important concept, that's what we call as in the non-cardiac pulmonary edema. So this one I will discuss in the next session. Okay, so don't worry about this one. And here is the assignment question for you all. So first assignment question is there in front of you all. Okay, flow rate of blue color venturi mask is dash. Question number 2, blue bladders seen in which dash condition. Question number 3, pink poppers seen in dash condition. So these are your very important questions. Question number 1 is the flow rate of the blue color venturi mask. Question number 2 is the blue bladder seen in which condition, and the question number 3 is the pink popper seen in which conditions. So I want your everybody's answer in the comment box at the end of this video. Okay, so Hope this particular video is very much helpful for you people. So we will meet again in the tomorrow session. Tab tak ke liye, Jai Hind, Jai Bharat. Take care. Love you all. Bye bye.